We're going to make a start, even if people continue to join us. So good morning, good afternoon, good evening for people joining us all around the world. Welcome to our webinar about improving hygiene program design in emergencies. A few points of housekeeping before we get started. So as I have mentioned, at the bottom right-hand corner of your screen, you'll find a small chat box. Please feel free to ask us questions throughout any time in this webinar. We are recording this webinar, so if you find it interesting, we'll make sure to share a link with you after the webinar so that you can share it with others. So this webinar is going to be all about improving hygiene program design in emergencies. This webinar will have three main parts. So the first part is that we're going to talk about the problem, and in this case that means that we're going to be discussing why we need to be promoting hand washing with soap during crises and why this is often harder than it may at first. Secondly, we're going to be introducing you to a potential solution, WashM. So WashM combines a set of assessment tools with a decision-making process so that you can design rapid, evidence-based and context-specific hand washing programs during crises. We will explain what the tools are and how they were developed. Lastly, we're going to share with you some case studies from different humanitarian crises where WashM has actually been used and tested. And we're going to let you know how you can actually become part of this testing and try out WashM for yourselves. But first, as a means of a quick introduction, my name is Sian and I'm the lead researcher on the WashM project, working at the London School of Hygiene and Tropical Medicine. And even though I'm going to be doing a lot of the talking today on this webinar, I want you to know that behind this webinar and behind the WashM project, there's a whole big group of us. So WashM is a partnership between LSHTM, the university I mentioned, Action contre la Femme, and CAWST. We're funded by the Office of US Foreign Disaster Assistance, USAID. The WashM team collectively have 75 years of experience working in humanitarian crises and specialist expertise in things like behavior change, WASH, mental health and care practices, educational design, and virtual services. So should you have any questions at any point, please do reach out to us, even if it's after this webinar. I'm now going to switch off my video so that we can delve into the problem itself. So the problem is probably one that you're very familiar with as WASH practitioners working in crises around the world. The reality is that in the acute phase of a crisis, diarrheal diseases cause about 40% of all mortality. This disproportionately affects children who, in conflict-affected settings, for example, are 20 times more likely to die from diarrhea than from violence itself. As a WASH practitioner, you probably already know that hand washing is our strongest defense against diarrhea. In fact, if we could get everyone to wash their hands with soap, we could reduce diarrhea by half. At the moment, hand washing programs look pretty similar in all different emergency crises. They typically involve distributing hygiene products and education about the health benefits of hand washing. Although being informed and having soap and water available is really important, these things are typically insufficient to actually change behavior. Furthermore, our programs rarely consider the vulnerability of the populations we are actually working with. We are often wrong to assume that hand washing could or should be the priority of people who've just had their lives fall apart because of an emergency. So let's take a moment to learn from a displaced person in the Democratic Republic of the Congo. He says, "I can tell you that I had a good life. I was rich, but everything changed when I was displaced. Now everything is bad. You cannot blame me if I don't always wash my hands. If you give me back my previous life, then you would see how my emotions and life would change. Then there will be a high chance that I will wash my hands with soap. It's good that organizations don't forget about us, but you come and you just talk about hand washing. We know what we should do, but we don't have soap and water here, and we are living like animals." So now I want to turn it over to you. In the right-hand side, you'll see an option to take a poll. And the question that I want to ask you is whether you believe that we can do hygiene promotion better. So you'll see that poll is active now. You've got an option for yes, no, or maybe. I'd be keen to see your responses. At WashM, we do believe that we can do better by crisis-affected populations. But why is it that good hygiene programs are so hard to design in an emergency? Well, we took time to learn from humanitarians working in crises in different parts of the world. These are some of the things that they told us about what makes hygiene programming hard. The first thing they said was, it's difficult to understand behavior, so we often pay specialist consultants to fly in and do the job for us. Is that something that you can also relate to? The second quote says, it's easy to train a WASH engineer, but so much harder to build capacity on behavior change. Is that something you can relate to as well? The next quote says, honestly, we've been working in this refugee camp for 3 years, but we just keep on doing the same approach over and over again, even though the population are bored of us. The next quote says, we do CAP surveys or needs assessments, but these are resource intensive and take time. Often we don't get the results until too late to influence the actual design of our program. Is this something that you found in your work as well? The next quote says, proposals are put together without much consideration for the local context. We just Google things and base proposals on our past experience. Is this something that you faced when you're rushing to put a proposal together in a short time frame? The next quote says, the population we work with knows the importance of hand washing, but there is a gap between knowledge and practice. The next quote is all about, we're now going to open up a second poll in the right-hand panel. If you have faced similar challenges to these, then please do indicate. So I can see that you agree that we can do better to promote hygiene and hand washing behavior in crises. Many of you are also saying that these are challenges that you also can relate to. So the obvious question that we might ask is, well, can't we just cut and paste what works to change behavior from what we know in non-emergency settings or stable settings and cut and paste that to emergencies? Well, the answer is unfortunately no. The evidence suggests that hand washing interventions work best when they draw on behavioral determinants and are adapted to the local context. But doing this takes a lot of time, resources, and capacity. A good hand washing program in a non-emergency setting will often be conducted over several months. You might spend several months on formative research, for example, and then many more months on actually designing your creative and innovative intervention. But in emergencies, that's time that we just don't have. You might also find that in an emergency, you have stretched resources and limited capacity too. Plus, when a person's world is disrupted by a crisis, this of course affects our behavior. We can't assume that hand washing is influenced by the same set of determinants as in a stable setting. This is why we need a slightly different or new approach. So could WashM be a realistic solution? This is what I'll explain to you now. Let me start by explaining what WashM actually is. WashM has two main parts. Firstly, we have developed 5 rapid assessment tools to explore the determinants of hand washing behavior. We have materials to help you learn about the tools. Then you would go out to conduct the tools in your local context and then return to the office with your data. The second part of WashM is a decision-making software. You enter your results into the software and it will generate for you context-specific program recommendations that are based on your findings. We have designed WashM to address many of the challenges that we discussed on the previous slides. So, for example, the whole purpose of WashM is to help humanitarian actors feel that hygiene behavior change is something that they are actually capable of. WashM allows you to design rapid programs that are evidence-based and that are context-adapted. But it also allows us to design programs that are sensitive to the needs of vulnerable, crisis-affected populations. So let me tell you about these 5 rapid assessment tools. The tools are quite different to standard approaches that are typically used within the sector. They're qualitative and not survey-based, so this makes them different from something like a knowledge, attitudes, and practice survey. They are designed to generate rich insights into actual behavior, rather than just simply asking people about whether or not they wash their hands. We know this isn't a particularly reliable method. Each of the 5 tools explores a different determinant of hand-washing behavior and generates data that can influence your actual program design. The good news is that we have designed the tools to be easy enough for anyone to use, irrespective of past experience or what area you work, whether it's monitoring and evaluation, WASH programming, or hygiene promotion. We also have training guides to help you learn these tools and to teach other members of your local teams. But probably the best news of all is that all 5 of these tools will only take you 1 day to learn and about 1 to 3 days to conduct, making them feasible even in the most acute phase of a crisis. So then, once you return to your office after collecting data with these tools, you can open up the free WashM software. You're guided through a set of multiple choice questions, which you'll answer. These questions will cover information about your context, your program design constraints, so for example, the duration that your program is running for and the amount of funding that you have available. Then you will enter a summary of the findings that you collected from your rapid assessment tools. What you will get out is recommendations that will cover these following components. So your recommendations will include a list of the specific aspects of hand-washing behavior that you should focus on changing. In different contexts, different parts of behavior will be necessary to focus on. For example, you might find that in some contexts, everyone washes their hands after the toilet, but that hand washing before eating is not quite as high. In that case, you would focus on targeting hand washing before eating. Your results will also indicate the key motivators for hand washing in your context. Based on this, it will develop a guiding story that you can use to convey your message. The reason we do this is because we know that humans for many, many years have used stories as a way of conveying messages and morals. We tend to remember a story much more effectively than we can remember a fact. The recommendations will also, most importantly, give you a set of innovative and evidence-based activities and recommended ways of delivering them. Because crises contexts are complex, we will also give you some tips and implementation guides for how to deliver your program successfully. Because of the way that WashM is designed, no 2 programs will be exactly the same. They will always be tailored specifically to your context. However, the recommendations generated by WashM will have certain key characteristics. Our approach generally discourages just teaching people about disease transmission or health, because unfortunately, numerous studies have shown that at the moment there is no indication of the fact that greater knowledge has an actual impact on behavior. Instead, we will give you activities that make people think differently about hand-washing behavior, that motivate them to take action, that change the physical environment so that hand-washing is convenient, desirable, and easy to practice, and that provide social rewards for good behavior. Ultimately, our combination of activities will help to make hand-washing normative. So now I want to briefly explain each of the 5 rapid assessment tools so that you can know what they would entail if you want to try them yourselves. The first tool, Handwashing Demonstration, is designed to understand how people interact with objects and infrastructure in their physical environment when practicing hand washing. This is a really quick method. It takes about 5 minutes, and it's done at the household level. You simply ask people to demonstrate how they would normally wash their hands after using the toilet or before eating, and ask their permission to video the process. When you watch that video back, you should assume that people are showing you the ideal version of their hand washing behavior. We know that hand washing is a very socially desirable behavior. And so, for example, we might expect that they're probably going to wash their hands for longer than they normally would. Your job is to be a bit of an investigator. You need to look for things that create barriers to good hand washing practice. For example, during the video, you might notice that the soap is kept far inside the house, making hand washing on a regular basis practical or impossible. The second method is motives, which helps us understand the underlying motivations influencing people's hand washing behavior. This is a method that we do within focus group discussions. It requires you to introduce participants to a set of character cards. For example, these characters include a person who is respected because of their education and wisdom, and a person who values having lots of friends. There are about 12 cards altogether. Participants are then asked to rank the characters according to who is most likely to always wash their hands. This normally results in some vibrant discussion and debate as to why people act in the ways that they do. This will help you to develop a story that you can influence your populations with. The third tool is risk perception. This helps you understand whether people feel that they are at risk of diarrhea. It's a tool that can easily be adapted to other diseases like cholera or Ebola if these are a particular concern in your area. This method is also done in focus group discussions. It uses a color-coded scale to explore people's perceptions of illness, to explore their perceived vulnerability, but also to try and understand how their perceived risk has changed because of the crisis. The fourth method is called personal histories. This method is actually not about hand washing at all. Instead, it's designed to understand people's experience of displacement, disease, or crisis. This is important to make sure that we design interventions that are sensitive to the needs of crisis-affected populations, and that we link this to other sectors like mental health and livelihoods. It's also really important because we know that hand-washing behavior doesn't occur in an isolated bubble. Instead, people's worries and their other priorities will affect whether or not they actually wash their hands. And that's what this method is designed to help us understand. This method is done at the household level. It uses a structured interview process, but it involves a lot of participation. For example, we start by the participant actually drawing some of their experiences, as you can see in this photo on the right-hand side. The last method is Touchpoints. Again, this is a method that is done in group discussions. This method is designed to help you understand the best ways to touch the lives of your population. So, for example, it will help you to assess the reach of a range of delivery channels that you might want to use. It will also help you identify whether those delivery channels could actually reach all segments of your population. So, for example, it puts a specific focus on people with disabilities, children, and people who are particularly poor within the population. So now I've provided you with an overview of the WashM tools. Probably some of you are excited at this point in time, but maybe others of you are having some of these thoughts. Perhaps you're thinking, I'm too busy. I probably don't have time to do this. Other people may be thinking, well, yeah, it sounds good, but motivating my colleagues to try this new approach is going to be really hard. Or maybe you're thinking, well, it sounds okay, but show me the evidence before I'm willing to try it. If this is the case, then this next part of the presentation is really aimed at you. So if you think that you're too busy to try the WashM tools, I encourage you to have a look at this table, which shows examples from where we've tried the WashM tools in other countries. You can see that on average across all of these different contexts, it took people about half a day to do the training. Even in South Sudan, where the team had a much lower level of literacy and they couldn't interpret the guides independently, it was still possible to do the training in 2.5 days. The time to collect the tools varied, but was about 1 to 3 days on average. And in fact, many teams managed to conduct the WashM tools in multiple sites during this period. I think the other thing that this table shows is that we now can say that these tools are feasible in all types of crises. You can see here they're being done for cholera outbreaks, typhoon response, Ebola outbreaks, internal displacement, and refugee displacement, but also that it can be done at all stages of a crisis. So I appreciate that when there is a crisis, it's often the last time when you would want to try out something new. Normally you want to avoid risk if you can. But don't worry, these tools are now being tested in countries all around the world. In the dark orange, you can see 14 locations where we've already completed testing of the WashM tools, and many others in light orange where we're planning to test over the coming months. If you need further motivation, it might help to know that everyone else in the sector is using WashM too. We've been fortunate to have all of the organizations on the left-hand side already test the tools in one country or another, including getting their local government and partners to work alongside them. The organizations on the right-hand side are committed to testing the tools in the coming months. If you're wondering about the evidence behind these tools, then this is the bit to pay attention to. As I said, the tools have been tested in 14 locations, and based on feedback from all of these countries, we've now been able to improve them so that we feel much more confident saying that these are valid and reliable. The good news is that today, on the 26th of March, we're releasing new versions of the 5 rapid assessment tools. I'll talk about where you can find them later. But the new versions of these tools have been tweaked and improved based on all of the feedback and learning from these different 14 countries. The bad news is that because this approach is relatively new, it's something that we're rolling out right now, we cannot yet tell you with confidence about the behavioral impact that a WashM designed program will have. But on the upside, by working with us over the coming few years, we can generate this evidence base and prove the value of this new approach. On this slide, for example, you can see a photo of a WashM output. Here's an example of new hand washing facilities that were installed after the typhoon recently that affected the Philippines. This was because of the team conducting WashM in this area. We also feel that we have kind of an ethical imperative to try something more innovative, given that we know that current behavior change approaches in emergencies are not working. The reason we think that WashM is a valid approach to try is because we're not aware of any other tools that have been specifically designed with emergency contexts in mind. Plus, it will probably reassure you to know that we did not design WashM overnight. Behind the tools and the software are several years of learning and research. We conducted literature reviews to understand hand-washing determinants. We conducted a grey literature review to understand which kind of documents and tools humanitarians are currently using and what the limitations or problems are with these documents. We interviewed lots of humanitarians in different contexts to try and understand the challenges and constraints of hygiene programming. And then we traveled to Iraq and the Democratic Republic of the Congo to understand more about the determinants of hand washing during crises and how these change at different times during a crisis. Now we're continuing to learn from our testers and always trying to improve our approach. So if you go to our website, which will be indicated on the last slide within this webinar, you'll find lots of case studies. But today I'm just going to highlight a few examples that are unique because they were examples of a WashM first. Let me show you what I mean. So the first example comes from ACF's work in Zimbabwe. They were the first organization to try the tools in truly an acute phase of an emergency. They managed to test the tools within 2 weeks of a cholera outbreak being declared in Harare. They also demonstrated just how quickly the tools could actually be done. They managed to do the whole process in 1.5 days. Here is a quick reflection on the process from Tom Heath, who's a WASH advisor at Action Contre la Femme. He said, "I realized that in all my years of experience, I've never really taken time to learn about the people behind the outbreak. By doing the WashM tool, we became more aware of the sensitivities of program design in an emergency like this, and came up with ways that we could share the voices and perspectives of people who had had cholera during our intervention." The next case study comes from the Philippines. This was the first time that the tools had been used in response to a disaster, Super Typhoon Ompong. The other unique thing about this case study is that the WASH cluster decided to use the tools collectively. All of the organizations working on hygiene came together to learn about the tools and then traveled together to the field site to collect the data alongside their local government counterparts. Then, when they returned, they held a dissemination meeting to share their findings with other cluster partners. The end result of doing the WashM tools in this way led to much more of a coordinated intervention approach and a stronger ability for each of those organizations to secure funding. This is what Paul Del Rosario, coordinator of the cluster, said about the approach. The WashM process is definitely more participatory compared to a mere survey, which tends to be too stiff. It provides opportunities to be able to link hygiene with other WASH issues. We plan to promote the tools to the wider cluster partners for application during emergency and disaster situations. The third case study comes from Goma in the Democratic Republic of the Congo. This was the first time that the tools were used for Ebola, and it was also the first time that MEDAIR actually managed to adapt the tools to be used for a preventative hygiene program. The key concern in Goma was that they did not want Ebola to spread from the more remote mountainous regions to the city of Goma. So they used these WashM tools to design that preventative hygiene program. This is what Tom Russell, WASH advisor for MEDAIR, said about the tools. In 1 week, we were able to both train our staff to use the WashM tools, as well as carry out the assessments. I get the sense that the WashM tools provided a way to dig a little deeper into the stories of the people we met. Greater depth than a wide-scale survey, and a lot less time and resources. Lastly, I wanted to share the work of Concern Worldwide. Concern are testing the tools in South Sudan, Lebanon, Somalia, Syria, Liberia, and DRC. And they have been the first organization to formally try and integrate WashM as a standard part of hygiene programming across all of their countries. Here's why Frank Fletchenberg explains that they made this decision. He says, "I'm so excited about the WashM tools. They are practical answers to the limitations that we have faced for so many years. It is now possible to apply best practices of behavior change science rapidly in an emergency." So now that you've learned more about the WashM process, I hope that you're keen to get involved. If you are, then here's what to do. So step 1 is to go to our website, which is washm.info. Here you can download the rapid assessment tools, read answers to some common questions, you can view more case studies, and you can watch some videos about the tools in action. One thing to look out for over the coming weeks is that we will be releasing all of the tools in French so that this can aid our Francophone counterparts. The second thing is that we'll also be uploading many more revised training materials over the coming week as well. Once you've had a look at the website and decided that you want to try the tools, then drop us an email at support washam.info. We'll be happy to answer any further questions that you might have over a Skype call, and then we can actually develop and plan with you. You can also ask questions via the online support hub. This is on our website. A box will pop up on the bottom right-hand corner whenever you log on. You might also want to connect with us on social media. We have Facebook and Twitter pages, and we try to keep these updated with news of testing from all over the world. Lastly, to make sure that you don't miss out on any of our regular updates, whether these are new releases of the tools or updated support materials or the release of the software in May, then please do sign up to our mailing list. So that's just about all from me. So now we're going to open up for questions. So I'm just going to review what questions we have. So the first question comes from Alex Wan, and he asks, a question for the presenters or attendees. Anyone planning to do this right now in the Cyclone Idai response? So that's a great question, Alex. Thanks very much. I have actually been in touch with WaterAid and their partner Plan International, who are considering using the tools for response in Mozambique or Malawi. But if anyone else is interested in using them, even during this acute phase of the response, then please don't hesitate to get in contact. It might also be possible that you could do it jointly with those other organizations. The next question comes from Bram Reams from ACF USA. So he asks, many hygiene promotion activities in emergencies don't just cover hand washing, but also food hygiene, open defecation, safe disposal of feces, access to safe water, etc. Any thoughts or experience on how WashM was integrated into larger hygiene promotion activities? Thanks very much for that question, Bram. It's an important one because, as you will have figured out from my discussion over the last few minutes, these tools are specific for exploring hand washing behavior. It is possible to adapt these to explore some other behaviors, but probably they're not the best placed tools to consider those other types of wash-related behaviors. Of course, it would be incorrect to assume that any hygiene program should focus only on hand washing behavior. The reason that these tools are tailored towards hand washing behavior is because we know that it is the most important behavior irrespective of crises, whereas many of the other hygiene behaviors you'll need to assess whether they are being practiced or whether it's an issue in your particular context. What you will find is that as you do the WashM tools, you become aware of a whole range of other issues. So you can use the WashM tools as a starting point to understand what are the other major wash issues, but also what are the other issues affecting people's livelihood or affecting people's mental health. These are often things that you find out indirectly by conducting the WashM tools. The next question comes from Ahmed Hassan, also from ACF, based in Kenya. Ahmed asks, is the decision-making tool a standalone software or is it web-based? If it is web-based, how will it help if there is no internet in the affected area? Thanks, Ahmed, for your question. So the software is available in a few different forms. You can download it from the website, but you can use it completely offline. So what you might do is you might perhaps go to an internet cafe or your office where you have good internet. You download it at that point, but then you can use it completely offline. If downloading it proves a problem, then let us know. We can also send it to you on a USB stick. So we tried to factor in that many of the contexts where we work, we won't have regular internet access. I should also just let you know that the software is currently not available. We will be releasing it towards the end of May this year, but at the moment you can still use all of the rapid assessment tools as they are. You share the results with us, and then we will provide recommendations within a maximum of 3 days. The next question comes from Victor Charo in Kenya. And Victor asks, which device do you need to install the software? Great question, Victor. So at the moment, our our software can work on any type of computer. We have designed this as a software that would be used on computers rather than mobile devices. And our thinking around this is really because we assume that someone within the office, the kind of person that would normally be putting together a proposal, is likely to always have a laptop. We also have made the tools designed so that you can go and collect the data without necessarily having to have fancy mobile tools or tablets or anything like this. The reason the tools are paper-based also is to promote greater discussion between members of your team. So the idea is that in the past, what we've tended to see is that often programs get designed by one senior person who might be working at a headquarters level, doesn't always know perhaps the reality of what the situation is on the ground. By making the tools paper-based and forcing different members of a team to have a discussion about how the program should be designed, we felt that that was better achieved through having a sort of a collaborative paper-based system that you would then enter into the software when you got into the office. The next question comes from Na Nguyen at USAID, and she asks, what are your thoughts about using WashM in non-emergency contexts in areas that are experiencing regular outbreaks of cholera? Thanks, Na. So, as you will have figured out, these tools have been specifically designed with emergencies in mind. So if you're working in a relatively stable development context that is not vulnerable to emergencies, then I would say these are not the best tools for you. You can use them, perhaps with the exception of the personal history method, which is very tailored to crises, but you can use all of the other tools and that won't be a problem. But perhaps you want to take time to dig into behavior a little bit more deeply because you have more time and resources. Having said that, if you're working in a stable setting that is vulnerable to crises or that typically experiences regular disasters or regular outbreaks, then these tools can be useful for you. And you can use them in a few different ways. What we would typically recommend is that sort of in advance of the next crisis occurring, you train several key staff within the WASH cluster or within organizations working on WASH. Because what we find is that these tools are a little bit different to other tools used in the sector. And so if you become familiar with them, then people find them very easy to use. But for the first time, it might be a little bit of a learning curve. So using them and trying them out when there isn't a crisis is really great preparation for when that crisis occurs. So we have actually done sort of preemptive training in a couple of contexts that perceive themselves to be vulnerable to crises. An example of this was a recent collaboration with the START network in Malawi, where we spoke to a few actors about being preemptively trained in the case that there should be another cholera outbreak in the country. The next question comes from Kathy Stephen in the UK. And Kathy asks, how did you decide which determinants to focus on in the rapid assessment tools? Thanks, Kathy. The answer to this question was largely based on the exploratory research, the in-depth research that we did in Iraq and Congo. This research allowed us to understand how behavior changes when a crisis occurs and how behavior continues to change at the different stages in crises. And what we realized is that in an emergency, we don't have much time. And so we're not going to have the ability to explore every determinant of behavior. Therefore, we decided to focus on the determinants that are most likely to vary by different contexts. So those were the ones that we ended up choosing. We also focused and prioritized, for example, the touchpoint activity, because we realized that it really does matter, it is really critical to take time to understand the best way of actually reaching your population. The next question comes from Joshua Knight, who works for the Global Hope Network in the USA. And Joshua asks, is it possible to use the material with minimal human resources? That's a great question, Joshua. And maybe to answer it, I'm just going to quickly scroll back to the table that I showed earlier. So what you can see here is that the amount of people that people have chosen to train in different regions really does vary quite a lot. What we have seen works best is probably training about 6 staff members. This allows you to break up into 3 teams when you're doing the data collection. So what we normally have is we have one team that is focused on collecting the hand washing demonstrations, another team of 2 people that are collecting the personal history method, and then another team of 2 people that are doing the focus group discussions. And we are able to combine a couple of activities in one focus group discussion. So as a minimum, we normally recommend doing about 3 focus groups, but we definitely encourage people to do more if they have time. So that is one model of doing it. As you can see, in some settings, people chose to train a lot more than 6 people. In some settings, we've also had people say, well, you know, our staff are so stretched already because they're involved in the current humanitarian response. We can't take them away from that for, you know, a period of days. So what they've chosen to do is just have 2 staff trained and collect the data on one method per week. So for example, on the Monday of week 1, they would go out and do the hand washing demonstration. And then they would continue with their regular activities for the rest of the week. On week 2, on Monday, they would go out and do the motives exercise and then continue with activities for the rest of the week. So this gives you an indication of different formats that you can use to actually test the tools and make sure that they work within your particular humanitarian resource constraints. The other thing that's probably worth mentioning is that on the line we do have quite a few people who've actually tried testing the tools. So for example, we have Benjamin Schaefer from who's based with ZOA in Afghanistan. I think we also have Nico Yap, who is based with ACF in the Philippines. So both of them have had personal experiences in trying the tools. And Benjamin from Afghanistan shares that based on their experience with Washam, they do feel that it can also be used quite well in non-emergency settings, and they're thinking of continuing to use it even in school settings where they work. So that probably brings us to the end of our discussion. I think there are no further questions for me to take up. However, if you're thinking about all of this and another question pops up, as I said, there are a range of ways to reach out to us. I'm just going to put that screen back up to finish. So please do jump online to washam.info and feel free to reach out to us either by email or through one of these other channels. As I said, this webinar is being recorded, and so we will send a link to you over the coming days so that you can share this with your other colleagues if you're hoping to get them motivated. Oh, we have one last question before we wrap up, and it comes from Ahmed. And he asks, is it possible to store the data or recommendations of an assessment done through Washam in a particular area that is frequently affected by disaster so that humanitarian actors can access and implement the previous recommendations instead of doing it again? That's a good question, Ahmed. So we do have or we will be building a process where you as individuals and organizations can choose to share your data set and recommendations with us. It's important to realize that when I say data set, it is a completely anonymous data set. There's no personal or confidential details within that. So what we can do when there is a new emergency in an area is we can certainly highlight to the WASH cluster or specific actors the regions where the tool has already been tried. We can share those findings with them. However, I would sort of recommend a small bit of caution, because sometimes it is worth trying the tools again, or at least trying some of the tools again in that new emergency. And I say that because our behavior does sometimes react differently over time. So for example, the first time you get a cholera outbreak in a country, there will probably be quite a lot of fear around the disease. The second, third, and fourth time you get a cholera outbreak in that country, behavior will actually respond quite differently. People will have become a little bit more used to cholera, and we might not see sort of an increase in hand washing in response to the outbreak that we saw for the first time. So I guess it's perfectly fine to draw on past experience to inform your programming, but it's always good to double check those assumptions and make sure that they haven't changed. So I think on that note, we will end the webinar. Thank you so much for joining in all corners of the world, and please do encourage others to view this once it's recorded and online. Thanks very much. And good luck in trying to design your hygiene programs better.